morning everyone. I am Dr. Afreen Parikh. I am Dr. Afreen Parikh, clinical scientist at RP Center, AIIMS Delhi. I will be presenting on clinical outcomes of minor salivary gland transplantation in cases with severe dry eye disease following Stevens-Johnson syndrome. This will be the outline of my presentation. Stevens-Johnson syndrome is a complex immunological disorder, dermatologically separating it from toxic epidemiological necrosis. It involves less than 10% of the body surface area. However, it predominantly involves the oral mucosa and conjunctiva. There are very few options in cases with very severe keratinization. One of them is minor salivary gland transplantation. Now, where to take the minor salivary glands from? They are present in large numbers in the label, buccal and palatal mucosa, and there are limited studies in literature on the outcomes of MSGT in chronic SJS. My study was an introspective interventional case series. It was done at RP Center for Ophthalmic Sciences. The inclusion criteria was patients with severe dry eye disease following chronic SJS. There was severe aqueous deficiency in the cases that were included with Schirmer score less than 5 mm. In cases with bilateral involvement, the eye with the worst parameters was taken and a minimum follow-up of 1 year was included. The cases which had active infection, ulceration or perforation at the enrollment were excluded, and those who were not willing to follow up were also excluded. All the cases were graded pre-operatively and 1 year post-operatively based on the grading criteria published by Sharma et al. This is how the procedure was done. This is how the graft was harvested. Pre-operatively, the patient was asked to do betadine or chlorhexidine gargles. After cleaning the oral mucosa with betadine, a marking of approximately 10 into 10 was done, and after infiltrating lignocaine and adrenaline, dissection was done of the graft. It was ensured that it was done at a deeper level so that the glands are sufficiently taken. Thereafter, using the pressure as well as cautery, the bleeders were stopped and the area was closed, buccal mucosa was closed with polylactin suture. Thereafter, the cotton was put so that there is no bleeding, excess bleeding. Now, for doing the transplantation earlier, we followed the technique of transplanting it to the superior rectus muscle. Firstly, after superior peritomy, the superior rectus was hooked and bridled. It was identified with bridle. Thereafter, the gland was placed on the muscle with the mucosal side down, and it was sutured to the superior rectus muscle such that there was a gland superior rectus complex with the mucosal side towards the superior rectus. Thereafter, the rest of the conjunctival closure was done. Post-operatively, the patient was asked to put topical antibiotic moxifloxacin, steroids, which was prednisolone phosphate, and lubricant drops. For the oral part, he was asked to use betadine or chlorhexidine gargles. Now the results was, we included 20 cases, 12 females and 8 males. Coming to the main results, there was improvement in the Schirmer, hyperemia, conjunctivalization, keratinization, neovascularization, Palisades-Vogt score, corneal opacity score. All were less than 0.05. As you can appreciate here, cases with very severe dry eye disease and keratinization were included, and 1 year post-operatively, there was marked improvement in the ocular surface. This was how they were on subsequent follow-ups. This was how the staining was also recorded. Now, MSGT, it is a procedure which improves sweatability and reduces inflammation, which improve objective scores. The advantage is that there is biosimilarity between tear saliva and oral mucosa conjunctiva. It is always easily accessible and universally available with no risk of rejection. It is a low-cost, simple technique and can be repeated. The limitations of the study was the quality of analysis of the subject was not done and lack of immunochemistry to see the saliva, how it came out after the implantation. To conclude, it is a viable and effective technique, and in future RCT would enhance the understanding of the disease. However, it would be very difficult to conduct an RCT in cases with SJS because of the rarity of the disease and numerable factors which are involved in the natural history. Thank you.
Thank you, doctor. Questions?
You said you put the gland, the buccal mucosa, mucosal surface down. Mucosal surface down means towards the rectus muscle or toward facing the conjunctiva?
Sir, the buccal mucosa, that
The
salivary
graft.
gland,
Yeah.
the gland was towards the superior rectus muscle.
Okay, that's right, because you said mucosa towards the spine,
Mistaken.
but showed it
Yes.
there.
Yes.
It has to be, the glands have to be, because they have to get the blood supply from the rectus
Yes.
muscle.